Hello everyone. We'll just let people join and come into the into us for the next session. And after this session, you're going to have a well-earned break where you can go and get a free lunch, free coffee, tea, and meet each other in the corridors, or you can sing with our choir, which will be on the screen during the break. So without further ado, I'm going to introduce a very good friend of mine, Neil Greenberger, who in fact, I probably hear his voice most days of the week as he's on Zoom calls with my husband, where I live. My husband, who will be one of the panelists later on, is involved in mental health of the workforce as well. But Neil is a very good friend who really knows everything there is to know about the impact of trauma on the mental health of people who are exposed to it, and in particular health workers, but also Neil has worked with army personnel, and he's really instrumental in trying to guide our response to how we should manage mental health currently through COVID. So hopefully we'll learn a lot, and we'll also get some discussion at the end. So Neil, over to you if you'd like to share your slides.
Sweet, great. So hopefully that's up there, which should be. Thank you very much indeed for asking me to speak here. And my intention is to speak for about 20 minutes and then allow some time for questions. You can see my Twitter handle there if you want to. I put most of the papers that I will talk about out on Twitter when they come out. As Claire's already introduced me, I'm a psychiatrist. I chair the Royal College of Psychiatrists Occupational Psychiatry Special Interest Group. So that's my real sort of interest. And I served in the Royal Navy for 23 years. And basically during COVID, I've been doing a bit of time setting up the mental health strategy for the London Nightingale Hospital when that was working, but also been advising and working with the NHS England and Improvement Wellbeing team, and also with Public Health England and Department of Health and Social Care. All the information I'm going to speak about is available at these websites. Particularly, I would point out the Health Protection Research Unit, which has been going for about 6 years at King's College London, where I work. And that was set up to look at the impacts of disasters and pandemics on organisations and nations. And so, as you can imagine, we've been pretty busy recently. During the current pandemic, there's no doubt that healthcare professionals have been exposed to a number of different stressors. There's been traumatic exposure, no matter really what area you're in. You know, I'm always taken by having spent quite a bit of time speaking to people in palliative care who have found it really challenging because they haven't been able to do things that they want to do, and obviously patients will suffer as a result. There's workload and shift patterns, and many of us have found that whether you're home working or whether you're going into hospital or primary care, it's been quite a grueling time for us. All of us have experienced home life stresses as well. You know, what's going on at home with our children, our families, and other people's jobs, and also sadly with bereavement for many of us. And then there's been what's called moral injury. And these are situations that clash with one's moral or ethical code. So that might be the junior doctor who's been asked to step up to go into intensive care and do work that is way beyond their normal competency. And you know, they may feel that they didn't do the right thing, or that they did something that they shouldn't have done. And of course, there's been the discussion also about being let down by our managers and by the government and by many other people. And all those situations can lead to what's called a moral injury, that whilst it's not a mental health problem by itself, it predisposes people to suffer with post-traumatic stress disorder, with depression, or sadly also with an increase in suicidality. One of the best studies on healthcare workers in particular, although we are doing some more work on that at this moment, this comes from the British Medical Journal a couple of months ago, Kisley et al. And this reviewed healthcare workers in previous pandemics. What you can see is that people exposed to a high related viral load, you know, in the patients that they're dealing with, were nearly twice as likely to suffer with post-traumatic stress and psychological distress. And I think what's important here is recognizing the particular at-risk groups. And most importantly are the younger and more junior and more inexperienced staff. They are definitely more at risk. I mean, interesting, in this particular review, they didn't find that Black, Asian, minority and ethnic groups were in that. I'm sure when we come to look at the current data that we're looking at, that we will find that as well. But there's also other issues there, including the important issue of stigma. It's important to say, I often get told, healthcare professionals are particularly difficult in terms of not asking for help. I hear exactly the same thing with police forces. I hear exactly the same thing with the military. And actually, when you look at it at a national level, as a nation, we're not particularly good at seeking help. So it's important to see stigma as something that's a national thing, not just something I think fits in with healthcare workers. One of the issues that's come up time and time again is this issue of personal protective equipment. Very interesting studies by Chen et al. Early on in the pandemic from China, who basically said that actually most of the workers out there, healthcare workers, weren't saying they needed psychologists, they just wanted the right equipment and enough rest. Showing that practical needs are really very much at the forefront of people's minds when it comes to their psychological well-being. But we were able to look at data we held on military personnel who have deployed to war zones over the last 10 years. Now, we've been surveying military personnel in war zones for a long time, and we'd always asked them a question about, did they feel they had the right equipment and right safety equipment, but we'd never really looked at that data. And so when the pandemic hit and the PPE story started coming out, what we did is to analyze that data on military personnel to see whether that could inform what we were seeing on the shop floor in the NHS. And we found that actually military personnel deployed to war zones who perceived not having the right equipment were between sort of 1.5 and 3 times more likely to have mental health disorders. Why is that important? Well, I don't know whether there was the right attempts to get enough PPE around. I've got no idea. But what I do know is that if staff are perceiving that they didn't get the right support with PPE, or they're complaining about PPE, persistently, that could be an indicator they may be suffering with mental health problems. So it's worth keeping that in mind. So what could you have done for staff before the pandemic, or as the pandemic was beginning to bite? This is important because, of course, we may have further waves. Well, before people started saying, yeah, I'll help out, I'll do this sort of work, we very much felt that the evidence says they should check on themselves about whether they were ready to take up that role. Were they, for instance, living with vulnerable people or people who were shielding? Were they going to be worried about taking the virus home with them and doing some real damage? Had they been involved in previous traumas before? Were they going through difficult, intense life stressors anyway that would predispose them to being more vulnerable doing this difficult work? Before people got going, we were very clear, particularly at Nightingale, to try and have what we called a frank preparatory briefing. So don't just say, thank you for volunteering, you're doing a great job. We needed to say, it's going to be hot, it's going to be sweaty, people are going to die no matter what you do. And of course, that's really important because what we need is for people to think about the challenges ahead of them before they actually get to the challenge themselves. That allows them to begin to make some sense of things. We also talked about what we called psychological PPE, which was the way of trying to develop a set of coping skills, practical coping skills, before you actually needed them. And one of the ways that you can do this is through what's called a wellness recovery action plan, which is the idea of noting down what it is that normally keeps you well when you're having tough times. And that might be places you go, on exercise, not very far from your home, people you speak to, films you watch, music you listen to, so that when you become distressed, you can turn to that plan and actually put in place what it's recommending. And then lastly, and probably most importantly, is all our evidence from other organizations that go through tough times is the better you can train people to do the task they're being asked to do, the better their psychological health is. So giving people training on how to use a ventilator or training on how to come up with the right drug regime was absolutely a way of protecting their mental health as well. One thing you won't see there is the use of pre-role or pre-deployment psychological health screening. Now, many organizations have this idea that you can somehow screen people and we're only going to put the psychologically tough people into the difficult jobs. The military had tried this for years with no success, and this was a really useful study, came out in February this year, published in Occupational Medicine, looking at the Australian police force in New South Wales. They routinely do psychological health screening for their police officers, and what this group of excellent researchers we work with at the Black Dog Institute did is to look at the results of those screenings and then look about how they predicted psychological health over the next 7 years of police service. And they found they predicted absolutely nothing. So I would strongly advise you against the idea of trying to screen people psychologically for their role. I think it could be dangerous because what it does is give supervisors a misguided view about actually how psychologically healthy people are. What about when you've got the situation ongoing? Well, we know there is excellent evidence that actually good social support and camaraderie at work makes a really big difference. So one thing we think that should happen is when teams are working, be that remotely or be that face-to-face, is people should be buddied up. And that means that actually, as well as all the other practical and operational tasks that you have to do on a particular shift or day, one of the things that you should have on your list is to be buddied with someone, and for both of your job is to keep an eye on each other. And so you're looking out, you've got each other's back as part of your routine day-to-day work. And if you've got a concern, then you should have a conversation with them. And if that doesn't seem to work, you should raise it to someone who's a supervisor. Now, all the research that we've done over the years, over the last 6 years in the Health Protection Research Unit and over the last 20 or 30 years in our military health studies, shows that the most important person in a team to protect the team's mental health is the immediate line manager, the immediate supervisor. So that might be the senior nurse in the GP practice. That might be the shift supervisor in an intensive care setting, whoever's looking after people that day. Those people in a healthcare setting, the supervisors, their attitudes and their ability to have a proper, decent conversation with staff members is critical to those staff members' mental health. In Afghanistan, we did studies where we looked at the health of troops who were deployed across difficult and challenging environments. And we found that troops who said my immediate supervisor was good, was caring in lots of different ways I won't go into, they had 1/10 of the rate of mental health problems compared to troops who said my immediate supervisor was not caring. This is the biggest bang for your buck, making sure that your supervisors can have psychologically savvy chats. Great study done in Australia in fire service, fire and rescue stations. They did a randomized controlled study, trained half of the supervisors how to have a psychologically savvy chat using a particular model. The outcome was that they knew a bit more, but most importantly, they practiced those skills and they felt more confident in having those conversations. They looked at sickness absence 6 months before and 6 months afterwards. They published it in Lancet Psychiatry, so the result was in pounds. And they found that for every pound invested in that training, they saved £10 in sickness absence over the following 6 months. So having a supervisor who actually can have a proper, decent conversation about mental health and feel confident to do so is really, really important. The end of a shift, people shouldn't just bomb burst and go home. They should have a chance to, what happened, what was good, what was bad, how am I doing now? Now, in an ideal world, they would get a bit of chance for reflective practice, but the ideal world doesn't always exist, because there's also maybe an opportunity to begin to change those views on moral injury, on the views of what went right and what went wrong. And then there's really good evidence that peer support also makes a difference. And this is the idea of having trained people who are just like you and me. So they are my colleagues who I can sit down and have a structured conversation with, but these colleagues know what they're looking for. We did a review published in the Journal of Traumatic Stress about 8 years ago now. And what we did is, this was a Delphi study, so lots of experts gave their views. And the idea was that peer supporters should provide a listening ear. They should be able to do low-level psychological interventions. Now, this is not talking psychotherapy. This is talking practical, solution-focused interventions. They should identify colleagues who might be at risk themselves or others, and they should know how to get those colleagues referred through to more professional help. One way that this has been done in the military, but also now in lots of other organisations, it started in the military, was through the use of this programme called TRIM, Trauma Risk Management. And this is the idea of training up frontline staff, be they chefs, be they diplomats, be they media professionals, be they nurses, doctors, healthcare professionals of any sort, how to have a structured conversation with a colleague in order to identify how they're doing. And if they're not doing well, you support them to start off with. And if they carry on not doing well, when you check on them, when you monitor them, then eventually you get them, help them to go forward and get a professional assessment. Did a big review published in 2015 in Occupational Medicine, basically showing that this is not penicillin for trauma, but this is a very credible way of providing support to people who are having a tough time. And then the last important aspect of how to sustain people is about what's the role for mental health professionals. And now it's really important here that mental health professionals who are helping to sustain staff who are doing challenging tasks don't get involved in delivering a normal healthcare model of illness-based, treatment-based, and time off. Instead, what they should be using is this approach called PIES. Now, PIES is basically the military psychiatry principles. I'll run through what they mean in a second. And these have been developed numerous times over the years, over the last 100 years, and refound. And great study done by the Israeli military, who did a 20-year follow-up study of Israeli troops who developed stress difficulties in the first Lebanon War, which was in 1982. So they followed them up for 20 years, published in the American Journal of Psychiatry, and they found the more these PIES principles put in place at the time that someone was distressed, the better their outcome was 20 years later on. So the first principle is the principle of proximity. And what that says is when someone's having a tough time, you don't just say, well, just go home, you know, if you can't cope. What you say is, how do we support you at work? How do we keep you near to where you're having a tough time? And what people need is extra support and often a temporary alteration in their stress or their pressure or what they're doing. So you can alter their duties maybe flexibly. At the Nightingale Hospital, if you were, instead of being in the intensive care inner side of the ward, you moved those sort of people into the don and doffing stations. So they were still being part of the team, but they weren't so exposed. And you can use a very similar analogies, you know, whether in primary care, in pharmacy, or wherever you might be within the NHS. So keep people near their colleagues, but just reduce their pressure a little bit and support them. Immediacy says that if some people are having problems, don't just accept, oh, I'm fine, as being the answer to how they're doing. If people are having difficulties, make sure you can have a proper psychologically savvy conversation with them and find out how they're doing. And you want to adopt a nip it in the bud approach. Solving problems early on before they become big crises is much more effective than waiting until someone becomes unwell. Expectancy has two bits to it. The first is that if people are having reactions to difficult circumstances, the expectation should be, this is probably a normal reaction. Many of us will experience these feelings and reactions and thoughts. And actually, this is not indicating you're unwell. This is indicating you're having a normal reaction and we're going to help you. But the other bit of expectancy says that actually, if this does go on and it starts to cause real difficulties, then what we will do is get you to the right sort of professional help. And the last thing is simplicity. Simplicity says that actually, if people are having a tough time, rather than jump to mental health interventions, try and think what you can do to practically problem solve the problem there. And I apologize for speaking very much about intensive care, but you know, my Nightingale experience was that if you had staff who were, say, pediatric audiologists whose stress and anxiety came from the fact that they couldn't manage the ventilator that they were asked to monitor, then actually they don't need a mental health intervention. What they need is someone to help mentor them and teach them how to use that ventilator better. So simple things, you know, a good night's sleep, a couple of decent meals, a chance to have a chat with people around you who matter, that can make a big difference. Mental health care is not the first intervention you should be doing. NICE, the National Institute for Health and Care Excellence, are really clear that we should not be doing psychological debriefing. You do not want psychologists or counsellors or psychiatrists like me coming in and worrying the frontline staff. The role for people like us is support the team, not to go in and provide early interventions. And the reason that NICE say don't do this is that not only does it not work, it has the potential to make people worse. And I don't know how well people know NICE, but NICE very rarely say don't do something. Normally NICE just stay silent on topics that the evidence isn't clear. So for NICE to say do not do it shows that there is evidence out there that this is not just not effective, that actually it can cause active harm. Probably worth saying, with lots of medics around, that actually for PTSD, which is not the only mental health problem we're talking about here, but drug treatments are not a first-line treatment. Or most importantly, benzodiazepines, you know, Valium and Ativan and those sorts of things are absolutely contraindicated. They actually can make PTSD worse. And then hopefully we're somewhere now in whatever this recovery phase is, you know, what can help here? Well, we know that having a thank you, a proper thank you, not just dear staff member, thank you for your work, you know, but dear Claire, thank you for the excellent leadership you have shown over blah, blah, blah. But having a proper thank you makes a difference to people's psychological health. It begins to help make sense of all the difficulties you've been through. It's also a really good time to provide people with information. As probably many of you will know, the NHS has had a national offer of lots of different services, mental health services available for staff since the pandemic started. And obviously lots of local services in primary care, secondary care, wherever, have also developed their own psychological health offerings. This is a time to remind people of what they are as they begin to try and make sense of what they've been through. If people have been working for a long time in arduous circumstances, it's vital they have a bit of a chance to recover, to reconnect with their loved ones, to reset where they are psychologically before they then go back into the catching up with all that work that hasn't been done. Once again, we come back to supervisors. Really, really good evidence that supervisors have, again, a critical role in helping people recover and get back into whatever this new normal is. And what that means is that a supervisor needs to have a chat with their staff to find out what they were doing, what they've done during COVID. Are they in a higher risk group? Might they be in, for instance, have a BAME background? Might they have had particular difficulties even before the pandemic started? And have they experienced any secondary stressors? How unfortunately has there been bereavement in the family? Has there been particular difficulties at home? Has their partner maybe lost their job and there's financial pressures? So unless a supervisor has those discussions with their staff member, they'll never know what's going on with them. Very important.
We've only got about another 8 minutes, so if we're going to have any time for questions.
We will. We're nearly there. We will do. So also important to have a time for reflection, a chance to speak about what's gone on, to try and make some sense of it. Nice and very clear about ongoing active monitoring. That's keeping an eye on people who have been exposed to trauma. We know that trauma doesn't always expose itself as being pathological early on, so you need to make sure that you keep an eye on people. And then where people do become unwell, they need to get evidence-based care. So this is my last slide, which is the basic principles are: do not over-medicalize, nip it in the bud, build team support as a priority, make sure your supervisors can have those psychologically savvy conversations. Where mental health teams have come involved, make sure you do as a PIES approach rather than an illness approach. Make sure you manage to come back to work properly and actively monitor people and make sure they get evidence-based care if they need them.
Fabulous. Thank you very much. Do you want to take your slides off? And I'm assuming that we'll have access to those slides. Neil, as ever, that was a fabulous talk. And I'm going to pick up some of the questions that have appeared on the timeline. But one I'd like, though, is one that fits in with my thoughts as well. GPs in particular, and hospital doctors as well, don't have supervisors. We don't have supervision. We don't have spaces for reflective practice. And certainly what we're seeing at practitioner health is the people that are suffering most, actually, if that's surgeons and dentists who have no access to employment at the moment, or very little, but also GPs who haven't got these spaces. I mean, what's your sense of how can we lobby the government or actually, find these?
So one of the interesting ways that NHS England are looking at the moment, and I don't know how this will manifest, is the idea of trying to make something along the line of a wellness check as part of the appraisal system. Now, I know this comes as, what does that mean, and how do you train appraisers to be able to do this, which is important. But there's something about having a bit of space in the regulatory side, which actually says you should look at your own psychological well-being as something that's important. It's not just an add-on. I think if you're in a workspace where there isn't a clear supervisor, and I think many staff do have people who are supervisors.
I think hospitals, certainly maybe consultants can tell me otherwise, but certainly GPs do not have supervisors. So 55,000 GPs do not have supervision in any shape or form.
Okay, well, if you haven't got a supervisor, then you certainly, I don't know, I would assume you'd have a peer group of some sort. You'd have people around.
I mean, I think that's the answer to your question, actually, is that we need to put these in place because we don't have peer groups. We don't. So I think what you're actually saying is the evidence translated from the army and from best practice. As for appraisal being a space for a cuddly chat, I think it starts to muddy up duties of disclosure, etc. But what you're actually saying is that
I agree. Yeah, we can get. I mean, the appraisal thing is a whole much bigger story. I know, but the key thing is that sitting with morally distressing events and traumatic events and difficulties by yourself is not a sensible thing to do. Yeah. That with the right space, wherever that is sharing it with someone who can properly listen and who might better help you practically problem solve what's going on is the way ahead.
Lovely. And somebody's asked, when do support groups for staff become psychological debriefing, and how can this be avoided?
Well, so the psychological debriefing side is about having people who are mental health professionals used to dealing with patients and hopefully doing it well, coming into a group of people who have been through an ordinarily traumatic experience. So I think the idea of having a reflective practice group, which is leader-led, talking about what went right and what went wrong and people's reactions, is absolutely good part of leadership. And I think that should happen. I think where it becomes psychological debriefing is when you start to look at messing people's reactions and trying to change them around and trying to use pathological terms to describe what are normal events. I mean, the literature about psychological debriefing showing it doesn't work and is harmful has been shown time and time again when you're using counsellors or debriefers or psychologists, you know, occasionally psychiatrists, who come in and try and use an illness model to overlay on what is, you know, a normal reaction to really challenging events.
Right. And there's somebody who's asked a question, Amanda Sidhu, who I know very well because I work with him in my charity, Doctors in Distress. And his question is, you know, how do we approach doctors who continually say they're okay? How can we actually say to them, well, you're not okay? And he actually has got a second question, which is about these places for reflective practice. But how do we persuade doctors to actually answer the question, no, I'm not okay?
So whether it's a psychologically savvy supervisor or a psychologically savvy peer, whichever psychologically savvy person it is, there are lots of quite simple techniques to try and help overcome people saying, I'm fine, I don't need any help, thanks very much. You know, so one simple way is to move from a conversation of how you're doing, you know, I'm okay, to a conversation of how you're doing, I'm okay, well, I'm glad you are. I have to say, I've been finding it pretty tough. Because then you begin to get into a meaningful conversation that, oh, well, actually, if you've been finding it tough, I have to say I have myself. So there are some simple techniques and levers that I think are very easily trainable and practicable that allow colleagues or supervisors to begin to have those conversations. The NHS generally is now rolling out something called REACT training, which is one way of doing that. And that's a free training package that they're running. So the thing is to have the confidence and skills to go beyond, I'm okay, thanks very much. I don't think you can tell people that they're not, because I don't think that generally telling people that you're not okay, you must do A, B, and C doesn't tend to work very well.
Neil, COVID has put a spotlight on well-being and mental health of health professionals in particular. But post-COVID, are we going to return to how we were pre-COVID, which was a pretty toxic, pretty demoralising staff for most people working in the NHS, with unbelievably high rates of depression, anxiety, post-traumatic stress disorder, on, and no space or time for reflective practice. And traumas are everyday traumas, even giving bad news. So how do you think we're going to go? Do you think this is going to be forgotten, that the fact that a lot of what you've done and many others have done during COVID is just going to disappear?
So, I mean, I can't speak for NHS England because I'm not formally part of it, but from my interactions with NHS people and the wellbeing team led there, and which is led by the deputy head of people, I know there is an intention to try and take the learning that we've had over the last 6 months and turn that into something in a people plan that makes sense. I also know there's lots of people who are more expert on NHS policy than me who say, yeah, but they've said that all before many, many times, and things never change. The other side I think to look at is a concept called post-traumatic growth that we don't speak about enough. Is actually, yes, there are absolutely people out there who will have been psychologically damaged, but we shouldn't ignore the fact that there are lots of people out there who will have done amazingly well and will have found the COVID experience actually has catapulted them into feeling really confident as a healthcare professional of many sorts.
Fabulous. And there's a question here which you probably have to answer briefly, because coming in from my dear friend J.S. Brammer, who says, should the NHS be prioritising NHS staff or COVID-affected NHS staff? And you've got about 30 seconds to answer it.
So in broad terms, military veterans are entitled to priority healthcare because somehow years ago it was decided that they have given their all to the country and therefore the country deserves that they should be at no disadvantage. My view is absolutely, NHS staff have absolutely shown, I know they always have, but they've shown over the last 6 months that they are a vital resource for the country. And therefore, because they have put themselves on the line, then the country needs to make sure that they too are at no disadvantage. So that means either giving them some sort of priority, or as for veterans, making sure there are mental health services specifically available for their needs.
Fabulous. And Neil, with 20 seconds left to go, I'd just like to thank you. Absolutely. You are, as ever, absolutely brilliant in how you speak and your experience, and also to thank you for all the hard work that you've been doing over the last 5 months in supporting the mental health of the workforce. And I wish you luck. And for those listening, you've now got a comfort break, so you can go and make yourself a cup of tea and you listen to the choir, and please come back for 2:20.